All right, hi everybody. We're going to wait for just one more minute as we get ready to go live here. I'm just going to set up. And as you can see, I have my little props. You can see my little man right here that I'll be using to illustrate why movements can cause low back pain and how, if we do not look at movements with low back pain, we are actually missing the boat as the movement specialist of the medical field. So we'll just take one more minute here as we wait for others to come online. Hope you guys are enjoying a nice evening, getting ready for Thanksgiving, time to be with family. So we'll just wait one more second here. I think what I want to do, I need to be able to, I'm going to just adjust this a little bit down so we get a better view here. How's that? Yep, that's going to work. All right. So, here we go. So, thanks for joining me. This is Dr. Wong from the Clinical Pattern Recognition team, coming to you live from Albuquerque, New Mexico, where I'll be spending time with family, and I hope you will be doing that too. And I'm thankful for being a part of a profession that can make very big changes in people's lives. So today, one of the key topics I want to talk about is how we as movement specialists can be a part of banishing low back pain in patients. So I'm looking forward to enjoying some time chatting with you about that. So for those of you who are live with me, I want to make sure, let me just make sure here that everything is on and going well, okay? I want to make sure that that we're able to interact. So get ready to type some thoughts in, and let's talk about getting good with managing low back problems, okay? So here's the case. Patient's a 37-year-old male. And he comes into you with significant low back pain. He's kind of rubbing both sides of his back, okay? In his movements, he tells you that there is no way he's been able to sit for very long. He can't bend over to pull on his socks or put on his shoes. He has a hard time getting in and out of the car, okay? And his mechanism of injury is 3 days ago, he was lifting his son out of the car seat, and the car seat is in the middle of his station wagon, in the middle row of the back row of the station wagon. So imagine, okay, if the patient's coming in and says, the way I hurt myself was coming through here and trying to lift my son, okay? Lift my son up. So let me move that out of the way a little bit. And immediately, as he's lifting, he feels a pulling sensation in his back. So think about that. Younger male who's complaining of high irritability of his low back problems, okay? And with his low back, he is unable to bend forward. When he comes back up, all he can do is push himself back up because it hurts so much. But when he goes into extension, he actually feels okay. So there's no significant pain reproduction. So all the pain is localized in the low back. And his mechanism of injury was lifting his son out of the car seat in the middle of their wagon. So it's not a very high roof. He had to bend forward to pick up the son. Okay, so for any of you who are out there, go ahead and put in your thoughts, what kind of pathology, what kind of low back pain do you think this is? So I'm just going to come a little bit closer to see if we have anybody who has an idea about what you're thinking in terms of the types of low back pain that is. So anybody out there? The person bends forward, picks up his son, feels something pull in his back, and now is having bilateral back pain. Okay? And he is unable to bend forward. He is unable to sit for very long. Alyssa's there. Perfect. Lumbar sprain or strain, disc pathology. In fact, That deserves a bell, I would say. Any other pathologies? So lumbar sprain and strain. Do we know in low back pain exactly what tissues are the cause or the source of the injury? Actually, as the movement specialist, we don't know the exact source, but we do know that the flexion movements, right, seem to bring on the pain, and returning from bending seem to bring on the pain as well. But going into backward bend seems to be painless. Okay, seems to not bring on any of the patient's symptoms. So, in your mind, you have an idea already that the patient might have sprained or strained some structure. And what kind of movement do you think brought on pathology in these tissues? Right? And you notice Alyssa said that could be disc pathology, that could be a sprain of a ligament, that could be a strain of a muscle, right? The source, it doesn't matter actually exactly what the source is. As a physical therapist, we may not exactly know, right? But we have some hypotheses about some movements that have caused this problem. So which movements do you think have resulted in this problem? Which movements are loading those posterior structures of the low back? Any thoughts out there? All right, so this is the lifting movement. I'm going to tie this in to this idea, okay, that the neutral spine is very difficult to injure, right? The loads on the tissues when your spine is in neutral are relatively minimal and the tissues are not at risk. This ties in very nicely to a guideline-based concept called back pain with movement coordination impairments, okay? This concept essentially says that the reason why people are having injuries, okay, having injuries related to structures in their back, are because when the joints move beyond neutral enough times, so that would be micro trauma, right, repetitive lifting, or a one-time trauma, all right? So imagine this guy is going to lift his axe off of the ground. Do you see how long the lever arm is? And depending on the weight of his axe, you multiply that weight, that load, by the lever arm, how much stress is going on into his low back structures, okay? So keep that in mind. The neutral spine is very hard to injure, but the spine that is loaded, now any number of structures, right? Any number of structures can become injured. So, the guideline-based concept, back pain with movement coordination impairments, says when the tissues move out of neutral too much, some surrounding tissues become pathologic, they become strained or sprained, it becomes a source of pain. Therefore, the treatment, the rehab strategy related to these conditions, okay, sprains and strains of the low back, and in studies that's been suggested that this type of back pain is the 70% of low back pain that walks in the door. Okay, so relatively benign stresses to tissues because of the way you load them. So that's one of the key concepts I want you to have in your mind. When people load structures repetitively or overload them, the tissues now become at risk. So the guideline says for these types of patients, put them in neutral, take them out of their end range positions or reduce them from going into end range positions. Right, this is me bending. Okay, put them in neutral where the tissues are on slack, the tissues are neutralized and minimally stressed, and teach them to function in neutral. In the early phases of rehab, we may just, if they're very acute, we may need to brace them. Even using an external brace for a couple days might reduce their symptoms. But they have to avoid, right, the aggravating movements. That's why the mechanism of injury and the aggravating factors. Remember the guy said, I have problems putting on my shoes. I have problems sitting for prolonged periods of time. I have problems lifting up my child from the ground. Can you hear that those are all talking about movements that stress structures. So for this particular type of patient, it's very important to consider that the guideline says for people who sprain themselves, who strain themselves by moving out of neutral too much, we need to put them in neutral, brace them, and when we talk about bracing, right, I've talked about external bracing, but what are some other forms of bracing that you guys are learning out in the clinic or that you're already using out in the clinic? What are the kinds of things that you do for these types of patients who move out of neutral too much? So let me just put that out there. What kind of things would you do for this patient? Okay, any thoughts out there? What kind of management would you use for someone who has sprained his back by moving too far out of neutral? Any thoughts out there? What did you learn for people who have lumbar instabilities, lumbar sprains and strains? All right, sorry about that. Looks like we got disconnected for a second. All right, Vincent said it has to be classified prior to treating. Exactly. So when you think about classifying, right, how do you classify this patient based on the guidelines? Last week we talked about mobility deficits. Does this guy have mobility deficits? Do you think that he has range limiting problems because of his joint or myofascia? Right? So I think we've all agreed at this point that one, this patient doesn't have leg pain. So that already removes a couple of categories of pathology, right? This is localized low back pain that is movement specific, of which lots of low back pain is. And his mechanism of injury is lifting something heavy, right? So he feels something pull in his back. And now he cannot bend forward. He cannot come back up. He kind of does this, right? Gower sign. He kind of pushes himself back up because, what? Activation of the sprained tissues or the strained tissues bring on the pain. So what kind of things would you do with this type of patient? What would be your management strategy? So let's see. If Alyssa has anything to say, Vincent, what do you think? What kind of things would you guys do to manage someone with a sprained and strained low back? Natalie's there, teach neutral spine. Yep, that's good. Anything else? Anything else that you guys would do for a patient who comes in and says, I cannot bend forward, I hurt myself lifting my child. I do not have leg pain. Okay? We'll save that for another day. So, remember this idea, right? The neutral spine is a spine that has minimal stress, the tissues are on relative slack, and it's very difficult to injure those tissues. So Vincent says, prior to making the jump to active tissues, one has to assess the directional preference. Perfect, right? So, would flexion be a direction of preference for the patient? No way, right? This reproduces my pain. I can't go in that direction. Now, what about coming up from flexion? That brings on my pain. Does that mean that extension, right? Is that his direction of preference? Well, the patient says, when I bend backwards from here, from neutral to extension, my back feels pretty good. Why do you think that is? Why is it that when he extends from here and comes up, he can't do it, but from here, he has no pain. He has barely any pain. From neutral into extension, no reproduction of symptoms. Any thoughts about that? Natalie, Vincent, Alyssa? Why would someone on the way up have so much pain but have no pain going from the top, neutral, back? So Vincent says, could be directional preference and unloading the posterior longitudinal ligament, or could be placing active tissues on slack. Brilliant. Exactly. You are talking about these structures. Yep, PLL can cause back pain from a slightly protruded disc. That's absolutely possible, and we haven't actually identified the exact source of the pain. But what we have identified are movements that are relatively pain-free. If it were me, and I think Vincent would agree, that moving towards being in a neutral or slightly extended position puts the irritated tissues on slack. Could we agree on that? And so, hence, the guideline-based principle that says when tissues are injured because you're moving out of neutral too much, the mechanism of treatment, the rehab strategy, is to put them into neutral and train them to move in other places. Okay, think about this. What if I said, keep your spine in neutral, turn on your abdominal brace, right? And whenever you need to go down to the ground to pick something up, keep your spine in neutral and use your hip hinge and your knee hinges, right? Can you see that the load on my spine is far different than the load on the tissues in my back? So, the management strategy is, remember all those things you guys are learning. What are some lumbar stave activities that you guys have learned or use in the clinic currently? Some common lumbar stave type activities that you guys would use. Yes, exactly. Dr. Boisnot, I wrote a chapter. Had the honor of writing a chapter in one of his primary care books. I've taken some of his courses. He's a fantastic guy, and that concept is exactly right. This is exactly what we do in physical therapy. In the pathologic tissue, we take that tissue and put it on slack. We put it in neutral and allow it to begin to heal. And then we teach them movement strategies that prevent overstressing that tissue. That's the general gist of movement coordination impairments. Teach them to move in other places, right? Teach them to move at their hips and knees and minimize the load. People won't get back pain. If you minimize the load and keep the spine closer to neutral, there's no more reason why they would get recurring injuries, recurring sprains and strains. Who knows? You might have protected their discs, of course, from the same movements, right? So, think about this. All of the lumbar stave activities that you do, right? So we've got supine marchers. We've got supine arms and leg movements. But remember, underlying all of these different therapeutic exercises, lumbar stave exercises that we use, it's a lumbar spine neutral position where the tissues are on slack. And you're teaching the patient to have motor control, right? Motor coordination to keep the spine in neutral while moving in other places, at the hips, in the arms, right? Some people who hurt their backs because every time they reach above their heads, they arch their back. Some people who hurt their backs because every time they lift their leg, they flex at their lumbar spine, right? Repetitive micro movements can absolutely be a cause of pathology. So, with that in mind, this movement coordination impairments idea that the injury is caused by moving too far out of neutral, stressing these structures around it, right, causing pathology. The way to manage these patients is to put them in neutral and strengthen the muscles like transversus abdominis, your obliques, your erector spinae, your multifidi. All of these deep stabilizers are there to help keep your spine closer to middle. And then to train their movements, right? You listen to the things that they do. Do you reach a lot and that's why your back hurts? Well, reach, but don't let your spine go into extension, right? Let me move that out of the way. And what happens when I bend forward? Hey, don't bend so much at your back. Bend more at your hips and knees and your spine, right? Your spine is safe. It is very difficult to hurt a tissue when it's in neutral, okay? So, with that in mind, this movement coordination impairments concept, this translates now, okay? This sets the stage for all the other sprains and strains that we're going to talk about in the body, So, can you think of any other areas in the body where tissues are injured because the joint moves too far out of neutral, whether it's from a trauma or from repetitive overuse, and there's sprains and strains of ligaments? So let me just put that out there. What are some other common, so this is all great, perfect, thank you, Vincent, for that comment. So think about this, okay? I'm just setting the stage for a conversation that we're going to have week after week, because we're going to use this same concept and then connect it to all these different pathologies. So what are some other problems? Charlie Johnson said glenohumeral joint. Think about this. The pitcher, right? At CSM this year, we spoke about pitchers and the common injuries that they have. And do you know why they're having all of these labral problems, impingement problems? The evidence shows that the thoracic spine is stiff. So when the thoracic spine is stiff and they can't rotate, they rotate more, excessive movement at the glenohumeral joint. When their hips don't move enough, right? So when their hips don't move enough, they try to generate velocity from the glenohumeral joint, and boom, the tissues become pathologic. Who else? Charlie's got anterior humeral glide, impaired PICR, right? Excessive movements, repetitive excessive movements, causing pathology to the tissues around it, largely because they're moving too much in one place and not enough at the other places. This is movement coordination impairments. That essentially is shoulder pain with movement coordination impairments. Perfect, Charlie. What else? What other common pathologies where injuries occur because tissues move too far out of neutral, whether it be from repetition or from a one-time trauma, and now you have some type of pain? What other pathologies can you think of that are based on this same principle? What else do you guys got? Let me put, while you guys are typing in, one other, think about the pitcher, okay? If his shoulder doesn't break down, femoral acetabular impingement, why does the patient have problems there? Because he moves too far out of neutral into flexion and begins to stress structures, right? Granted, in that particular case, many times there is some type of an anatomical abnormality, but yeah. Okay, Vincent's got ischemic low back pain, good. Okay, what about the pitcher? Does he have, besides his shoulder, what's another common area that gets sprained? Yep, Vincent's saying any posture that we hold statically for long periods of time eventually load the tissues and may precede failure, right? Vincent's got ulnar collateral ligament. Let me cut to the chase here, and that's absolutely correct. Vincent's got it right on. When the joint moves too far out of neutral, we have the knee. We've got the knee problems, right? If you looked, I'm going to just focus this down a little bit. If I get hit from the inside, my joint moves too far out of neutral, my MCL gets sprained. Jess is on. What's up, Jess? Elbow problems, right? We talked about elbow problems. Look at ankle problems. I just sprained my ankle. My joint moved too far out of neutral and sprained the structures around it. The same mechanism, right? The same mechanism is what brings on the pain. So, when you have a knee sprain, when you have an ankle sprain, when you have an elbow sprain or a wrist sprain, right? I fell on my wrist. My joint went too far out of neutral, and now the structures in my wrist, in my elbow, in my knee, in my ankle, they're sprained. Based on the guideline-based rehab concept, we brace the tissue in the middle. That's why we wear knee braces. That's why we use ankle braces. That's why we use wrist braces, elbow braces, tape the shoulder, because we're trying to put the joint in neutral where it can heal and it's minimally stressed. We educate the patients on the movements that they shouldn't do, right? I would tell a pitcher, do not throw for now because the tissues need to recover. The shoulder, the elbow. And in the meantime, I'm going to restore mobility and restore hip mobility while these tissues are recovering so that these tissues might be able to stay neutral a little bit better. And I'm going to teach them to move in other places, and that's how you help these patients recover. So, you guys, this idea of sprains and strains, how the injury occurs when you move too far out of neutral, right? And the rehab concept of STABE, putting the tissues in the middle and giving it some time and restoring mobility in the other regions so that they can actually move in other places, that's how you're going to help lumbar sprains and strains. Something as simple as a lumbar sprain and strain, right? 70% of the patients coming in need you to educate them about how to move that minimally stresses tissues, right? Let me put out 2 more thoughts, and then we'll call it the day so that we can all enjoy time with our family. In the lumbar spine, we have essentially said there's 3 main movement faults, and then they can be combos, of course, but 3 main movement faults. People, and I'm going to just focus this a little bit here, people who move in excessive flexion, right? Their preference of movement is excessive flexion. So they hurt their ligaments, they sprain their muscles, they sprain their ligaments and strain their muscles, and eventually they blow out their discs, right? So people who excessively flex, I bend and lift things all the time. I sit all day. I drive and then I lift heavy things out of my truck, right? Excessive flexion people. There's also excessive extension people. People who have pathology because the things that they do are always related to extension and rotation, twisting, extending. You have to listen for it. You have to observe their postures. Are they always extended? And the things that they do, their preference of movement is extension, right? I need to train them. Turn on your brace, keep your spine closer to middle, and then teach them to move in ways that do not compromise the low back, right? And the last one is rotation. So 3 main common movement faults in low back pain, and I'm going to apply these same movement faults as we go into leg pain, radiculopathy, disc pain, disc-related leg pain. We're going to talk about these same movements because without understanding that the movements can drive the pathology, and the movement specialist who is going to change your movement strategies so that you don't keep stressing these tissues, if we don't have that in our mind, then pushing around on the low back is all for nothing, right? We're the movement specialist. We're the ones who can listen to what you do, identify patterns of movements that are stressful to tissues, and train you to move a different way. This is my hope for you. If the next generation of movement specialists will see the world through a lens that says, I know what normal and optimal movements look like. Normal optimal movements look like this, right? Even if I have to bend, okay, let me just make one illustration here. Even if I have to bend to pick something up off of the ground, if I bend like this, can you see that I'm set up for injury? Guaranteed, pretty much. It's just the right timing, the right load, I'm in trouble. But imagine if my movement strategy was neutral, neutral, neutral. This is hip flexion, knee flexion, and now I bend a little to pick something up off of the ground, right? Can you see how the loading on the low back is completely changed? Can you see how someone who picks things up and pulls themselves up with their erector spinae, can you see the loads on the muscle? Can you also see that if I pick things up here, and I extend at the hips, extend at the knees, extend, and now I extend at the lumbar, the loads have completely changed. And that's why people have low back muscle strains, because of the way they lift the loads. It's lever arm times load. That's it. You change the way that they move, you've changed low back pain. They'll get better. Put them towards neutral. Train the brace. Teach them to assume postures that are more near the middle. Don't let the extremities wag the low back. And essentially you have the main guideline-based concept of back pain with movement coordination impairments. That's how we treat sprains and strains. That's why lumbar stave works, because you're keeping the spine in neutral. And you notice how many of our lumbar stave activities, they start in supine, right? Because it's gravity eliminated. There's no stress to the tissues, right? So from there, you can see that neutral spine, training of the muscles that help to stabilize the spine, stretching of the muscles, right, hamstrings and hip flexors that threaten to pull you into poor postures based on their length. You modify those tissues and train their neutral spine and teach them movement strategies. You have just helped 70% of low back pain patients walking in. Heavily related to movement. Okay, think about that. How critical it is to have this rehab concept that says tissues in neutral are really hard to injure. And so as a movement specialist, I'm going to teach you ways to move and to function in life that keep the tissues mostly in neutral, or for short periods, maybe slightly out of neutral, but I'm going to teach you ways to minimize loads on those tissues. Okay? So, I probably went a little bit long. I want you to remember dude and why he gets injured, because lever arm times load equals stress to tissues, right? And I want to say happy Thanksgiving to all of my students, all of you out there eager to become movement specialists. I'm excited to be a part of that with you, and I hope that that concept that there are 3 particular types of faulty movements that happen in the lumbar spine: excessive flexion, excessive extension, and excessive rotation. Because we know from the research that rotation, right, it tears the disc up. And so we'll use that, we'll lever those concepts into how we manage every single form of low back pain. How we'll use movement to help people with low back pain. There might be just mild modifications related to nerve problems, disc problems, but the concept related to movement is universal and is critical for us as a profession and as movement specialists. Right? So I hope you guys have a wonderful Thanksgiving. I'm looking forward to hanging out with you guys again next week. Next week we're going to talk about leg pain, right? Back pain with leg pain. So you guys have a great evening. Happy Thanksgiving. Enjoy time with family, because this is what it's all about. All right? Cheers, everybody.